Good evening, and welcome to this special edition of Doctors on Call on the COVID-19 pandemic. I'm Dr. Paula Termuhlen, Regional Campus Dean at the University of Minnesota Medical School Duluth Campus, and I'm your host for our program tonight. We're continuing this series of special programs to answer viewer questions about the coronavirus. As testing continues to ramp up around the state, we're getting a better picture of the extent of the virus in our region. Tonight's guests will share the latest information they have to help keep you and your family safe. The telephone numbers and email address for your questions can be found at the bottom of your screen, and we have lots to get started with tonight. We want to welcome back our panelists this evening, Dr. Harmony Tyner, Infectious Disease Specialist with St. Luke's Infectious Disease Associates, and Dr. Rajesh Prabhu, Infectious Disease Specialist at Essentia Health. Members of the WDSE staff are standing by to take your calls and emails, and once again, we really are very grateful for the care with which they have taken to make sure that we're safe. We're social distancing, and there's all kinds of masks and hand sanitizer here, so we feel very good about the work that we're doing. So once again, we have many questions that have come in from viewers, some from a couple of weeks ago, some from this week, and we look forward to having more tonight. So let's get started. So Dr. Tyner, you know, it's been a couple weeks since you and Dr. Prabhu have been here on the show, and can you just remind everybody, what are we hearing now about the symptoms of COVID?
Good question. It's always good to be reminded. So we've all talked about having a viral illness, and like most viral illnesses, this often will start with muscle aches and fevers. People will often experience a cough and shortness of breath as well. In severe cases, some people will have very mild illness and only experience a sore throat and some muscle aches, and some may not have any symptoms at all, which makes it kind of confusing. But other things we've talked about that kind of are unique to this virus seem to be maybe some people will lose a sense of smell or a sense of taste. Some people have had discoloration of their toes or their fingers. So a couple of new things have entered the picture, but really it's a viral illness. Muscle aches, fevers, cough, shortness of breath are the big ones.
Well, and so Dr. Prabhu, you've taken care of a number of patients now with COVID. Can you give us sort of a flavor of what it's actually like when someone has it?
Well, I think the unique thing about this, Dr. Tyner talked about shortness of breath, but a lot of people don't feel that. It's almost a late finding. So people have probably heard that, you know, if you check your oxygen levels, some of these patients have low oxygen levels, but they don't appear to be short of breath. And so early on in the illness, so that's why people present kind of late to the hospital, is it kind of, after the first week is really the danger point. Are you going to get better, or are you going to take a turn for the worse?
Interesting. And I've heard a little bit, at least I've read in the news, is that especially things like the loss of taste and the loss of smell seem to be something that persists for a while, and that there may be things like depression that are associated with the illness. So I guess we'll have to stay tuned as we find out more about what people are like when they recover. Mm-hmm. But that brings us to, I think, the next category of things we were talking a little bit about ahead of time, which is what are some of the treatments that are starting to emerge? I know that's been in the news actually in the last couple of days.
So, I mean, the two big things that are in the news is remdesivir, which is the antiviral, and this convalescent plasma, meaning people that have had COVID-19, we harvest their plasma and donate it to patients to help them fight the infection.
I think it's useful to say that the vast majority of what we do to help people recover is just to support them, give them oxygen, help them breathe, and give them breathing treatments. There's no really proven treatment for this that's been shown to be useful.
Well, and so we had a couple of viewers that were curious about if breathing exercises can be of help to someone who has COVID-19, especially if they're recovering at home.
When people are recovering from a respiratory infection in general, oftentimes they'll have inflammation in their lungs or have kind of secretions, things you cough up. You might notice when you complete a cold that you have a runny nose or a cough for a while. Breathing in deep helps open up your lungs all the way, and continuing to walk around and get as much exercise as possible. If you're given inhalers to use them. Sometimes moist air is good too.
Well, I know we've heard a little bit about positioning of patients in the hospital. I heard that you could lay someone on their abdomen or on their belly, and that seemed to make a difference. Do you think that might be helpful at home?
Actually, I mean, the thought is even people that are hospitalized, having them try to lay on their belly. What I've heard from other doctors, the critical care doctors, sometimes it's difficult for a person to actually stay in that position for a long period of time. And I think the point of that is trying to expand different parts of the lung to get more oxygen in those parts. But I think the biggest thing, if you're at home, you're probably not sick enough to go to the hospital. As Dr. Tyner says, try to be as active as possible, and don't smoke if you smoke.
Okay. So we had a number of questions this week from viewers that have a variety of different conditions already that they're curious about if that puts them at higher risk. So one person knows that they have angioedema and wants to know if that makes them more susceptible. And I'm assuming a sort of angioedema that might occur in their lungs or.
I'm not sure specifically about angioedema. I can say that people who are at risk for angioedema or lymphedema, being overweight and having diabetes and having poor lungs to start with can put you at higher risk. But I can't speak to angioedema specifically. Well,
and that's actually a segue into another question we had, which was around sleep apnea. A lot of people have sleep apnea. Does that put someone at higher risk?
I think it may make it more difficult if you get a case of COVID-19 in terms of how severe your illness is.
Okay, and people, some people who have sleep apnea have CPAP machines at home. Do we know anything about whether or not the virus can live in there or if it could actually be beneficials?
I would say if you use a CPAP machine, you should continue using it. We know that most of the virus is transmitted through speaking, coughing, talking. It's carried by the respiratory droplets. We talk about surfaces that can become contaminated, and if it's your CPAP machine, only your germs are getting on it. So unless you share it, which you probably shouldn't be doing, you should be fine with your
Even
CPAP
when we don't
machine.
have a pandemic, you shouldn't be sharing your
Correct.
CPAP machine. So.
Exactly.
Right. Well, and I think on that related topic, because every week we've had questions about masks, they're becoming more popular. So the cloth masks that many of us are wearing now and making for ourselves, who's that protecting? You, or is that protecting the public?
I mean, the purpose of that is people have heard of this asymptomatic state, meaning you may have COVID-19 before symptoms develop. So the purpose of the mask is to prevent you from actually transmitting the virus to other people when you're thinking you're feeling well.
Yeah, you don't even know you have it, right? So you
Correct.
could be at the grocery store and infecting someone without even realizing it. So.
And it's like, 24, 48 hours, even up to 3 days that you may have virus spewing from your mouth when you're talking and not feeling well.
Well, and that's again part of that six foot distance at least to try to keep that, to minimize the impact of that. Okay. So hip replacements, do we know anything about for patients who have hip replacements, does that make them more vulnerable?
No, not unless your risk factors for having a hip replacement include obesity or other diabetes, etc.
Okay, so some of the other chronic conditions.
Yeah, but not the hip itself, no.
Okay. We talked a little bit a couple weeks ago about high blood pressure can, again, as a chronic illness, may make people a little bit more susceptible. But this caller wants to know whether or not controlled or uncontrolled, does it make a difference if your blood pressure is controlled or not? Do we know?
I haven't heard that. I just know that they list high blood pressure as maybe a risk factor, but they haven't gone into that much detail, controlled or not controlled.
Yeah, and I think that would be almost similar to, I would presume, like diabetes. We know some patients are under very tight control, others really are struggling to get there. Where they are on that spectrum, we just don't know what the impact of that is yet. So, okay. So here's someone who has a pacemaker and a couple of stents and wants to know if they could protect themselves by using their sauna and heating it up.
I have a sauna, and I love my sauna, and it's a sauna, as the person who wrote that question probably knows. It's probably Finnish.
Sauna.
Yeah. Truthfully, it helps your cardiovascular health, so it's healthy to do. It probably won't save you per se, but it certainly won't hurt you, and I encourage its use.
Yeah, there's a lot of things in medicine where if it doesn't hurt you, but it might help you, why
That's
not,
right.
right? Okay. We had, I feel like it was really important that we got some of these questions on that we've been accumulating over the last couple of weeks because a lot of individuals have, maybe not themselves, but others around them that they are concerned about their risk. So this caller has a daycare and wants to know if the children at the daycare and their parents could put that daycare owner at risk, and should the children wear masks?
So, I mean, people have heard now that we've expanded testing to anyone that has symptoms in Minnesota that you think that are concerned for COVID-19. And before they made that sort of change, child caregivers were in that priority list because they're taking care of people in a congregate setting, many little kids around. But the interesting thing about kids, and it's still to be determined, it almost seems that the kids like under 10 years of age, when they've studied this in different populations, they don't seem to find infection in them, but the kids that are older, they do find them, but still all kids seem to have minimal symptoms. And I would think it would be difficult to mask kids in a child care setting.
Yeah, I think in Europe I thought I saw that they've been trying it, but I agree. It'd be pretty hard for an active 5 or 6 year old to have, or younger to have a mask on all the time. But I also, if I understand correctly, with children, most illnesses, many illnesses, are in fact commonly seen in the child population, the pediatric population, and they give it to the adults. This feels a little reverse. Is that true?
I don't think we know enough about it yet. We know that people who have milder illness tend not to have a significant antibody response to it. The more severe your illness, the more significant your antibody response to it. And in kids, they just have a very mild presentation, and so tend to have a very mild antibody response, if any at all. So some kids have gotten sick, and some have even passed away. We've seen that in the news, but in general, much more mild condition. Did that answer the question?
Yeah, sure. And I think, and I think that's also a good reminder that just like adults, children who have chronic illnesses or may have had congenital problems are also children that are part of that high-risk population who could be impacted by COVID. You mentioned the word antibody. So let's talk about antibody testing, because there's a lot in the news going on right now about that. So what is antibody testing? And should that be something we should be doing, and who should we be offering it to? Who wants to take that one?
Many questions right there.
Yeah.
I can touch on what antibody testing is if you want to talk about who should get it.
Antibody
testing is looking for the marker in your blood to see if you've been exposed to an infection before. So the way the body protects you against getting something in the future or remembering something it's seen before, is to make this little protein called an antibody that remembers an infection from before. Sometimes the body remembering that infection also protects you against it. Not in every infection. For example, hepatitis C, if you get it before and you get treated or cured, you can get it again. So some infections you can be protected from the antibody, for example, like chickenpox. Well, no, that's not a very good example. I should say other vaccines we have against infections that you get as a child, like polio. If you have a polio antibody, you could never get polio. But it's different for each infection. So having that little marker in your blood to say if you've been exposed to an infection before, if you've had the infection before, is what the antibodies are.
So if I understand correctly, you're saying that we don't know whether having those antibodies are really going to be protective. In fact, we're starting to suggest that maybe they're not protective.
We don't know. We hope that they are, but we honestly don't know. We really hope that they are, but there's no evidence to say one way or the other right now.
But we can test for the antibody to know whether or not someone's had the disease or been exposed.
It's kind of scary to suggest someone get a test for the antibody to give them the false impression that they might be protected. All it means is if you have an antibody that at one time in the past you've had this virus. That's all it means. It doesn't mean that you're necessarily protected against it in the future. If we come to find out that it is protective, then that will mean that, but we don't know that right now.
We don't.
Yeah.
Okay. And so Dr. Prabhu, talking a little bit about who might be a good, what are some of the populations beyond those that might have illness that we should maybe be testing? For example, like those living in assisted living facilities.
So I see this test to see if you've had exposure or not. So one situation is it's a person you suspect has COVID-19, but these PCR tests are negative, and that can mean maybe you tested too early or you tested too late, meaning there's only a certain finite period of time that you can detect it in a nose sample or a throat sample. Or if you have someone that's really ill in the hospital and you think, boy, I really think they still have COVID-19, our tests are negative, you can do that antibody test probably about 2 weeks out, and if it's positive, it tells you, yes, this illness that you've had is COVID-19 related. In terms of facilities, nursing homes, et cetera, which is a high risk for passing this virus around, I still think that the PCR test is your best bet in terms of if you really want to make sure, does this resident have COVID-19, the PCR would be the way to go.
Do we know yet between the PCR testing, which is the swabs, right, and the antibody testing, which is a blood test, do we know if those can, between the two, tell us if somebody's actively shedding?
So the PCR tells you if you're actively shedding.
Okay, so you can infect someone else.
Correct. Or the antibody test is yes, you've been exposed or not. The PCR, the other thing about the PCR is people have heard you could be shedding this virus for weeks. It doesn't mean that you're infectious for weeks. So recently I heard from a Department of Health call that the CDC is actually culturing this virus every day they do the PCR. And they found that by day 9 or 10, they can't actually culture the virus out, meaning it's dead.
Okay.
Though the PCR can remain positive.
So in other words, we've got a lot to learn, it feels like, in this whole testing zone, but just compared to when the two of you were with us a few weeks back, I think we understand so much more now, and we have this additional test that we didn't even have then. So really rapidly turning that around. So speaking of testing, since both of you represent our Duluth health systems here, are we offering both types of tests at our facilities here in town?
We're able to offer both of them, yeah. If you think you may be sick, or if you have symptoms, we do actually suggest that anybody with symptoms can be tested. And at St. Luke's, we have a drive-through clinic for anybody with infectious symptoms or symptoms of a virus that you can visit. Up until very recently, we only suggested people with certain risk factors and people who are hospitalized to be tested. That's expanded. And since there's enough test availability that we actually suggest anyone who's symptomatic to be tested.
And I heard a little bit about that, about the expanded testing. So you want to take that too?
So it's the purpose is for anyone that has symptoms, and the great thing about that is we have now a chance to contain this sort of pandemic. Before, we were just testing a very small percentage of the population. And if we want to sort of protect the people that are at highest risk, the elderly, people with underlying health conditions, you really need to find out who the people around them have the virus. So at the moment, we were just testing the people at highest risk, but we weren't necessarily testing the people that could pass it on to them.
So in other words, like I know we've talked a little bit on the show about contact tracing. So someone gets infected, we find out who they've been around for a period of time. Are we at the place where we could actually test those individuals if they had been around someone?
We do have enough tests to do that. There's a little bit of a kind of an asterisk next to that, kind of like, yeah, we could test them. If they're not symptomatic, we know that early on in infection, even if you've been exposed, you may not yet have a positive test, so we still suggest you watch for symptoms. But yes, you could test them if you wanted to. It's also going to make it a little more confusing to interpret how many positive tests we have. We see the numbers in Minnesota kind of skyrocketing right now, and with expanding the tests, we're testing people we previously wouldn't have been testing. So it's hard to know how much of that is really seeing the infection accelerate and how much of that's just an artifact of testing more people.
Well, and that's going to actually play into then the death rate ultimately of this particular disease, because the more people we test, the more people we understand have actually had it, will change whether our understanding of how lethal this virus is. So. Well, we've gotten a few other questions tonight that are now talking about, for example, food processing professionals. And we've heard a lot about that in the news. And what makes them more at risk for contracting and spreading the virus?
I think, regarding like this pork handling, it's more related to how close all these people are and depending on their job environment. In the hospital, we have a lot of protective measures that we've put in place to try to protect the healthcare worker from getting infected, trying to prevent visitors and patients coming into the office from getting infected. And my guess is those same measures weren't done in the same degree in sort of typical factories. But in healthcare, we're used to doing that. We're talking about COVID-19 now, but we do that day in, day out for other infectious diseases to prevent spread.
Yeah, okay. We have another caller who'd like to know, if you have type A blood, do we know if that makes you more at risk than people who have type O blood?
There was very, very early data on that there was a few people who thought that might be the case. I don't think we know enough to say one way or another, but right now it doesn't seem like that makes a meaningful difference.
Okay. We do have a question about masks. So, and that is there any information about copper-infused masks, and if that may make a difference, and if so, where might they be available?
I've not heard of that. Have you?
I think I've read something recently. I guess copper in itself, they studied viruses, how long can they live on a copper surface. So I think maybe the theoretical benefit may be it doesn't survive as long on that sort of cloth type material that's infused with copper.
Sounds uncomfortable.
Agreed. So we've had several questions just around public health. And this caller would like to know, why are we not in St. Louis County specifying where the cases are located within the county?
That's a good question. And I think it has to do with patient privacy. So one of the things we do prioritize with people who have infections is the individual rights of the patient. So we report by county because that is important for epidemiology, but it's not important to know their house address or the block. It's not necessary. It doesn't change anything. And it also would violate patients' privacy.
Well, and it's a false sense of security. So let's say, for example, that there was a case in Hibbing. You might think if you're in Virginia that you're safe, but in fact, as we've been just talking, you could it's really community spread right now.
Correct.
Okay. So how long do we think COVID-19's been around? Because we've got some curious emailers wanting to know how long do we really think this has been here?
Well, I mean, if it was declared in December in China, and people were obviously traveling between China to Europe to the United States, so theoretically it could be certainly before that. I think early on, most of the cases that at least were identified were travel related, meaning you had to have a history of travel to China or to Europe, a hotspot. But right now it's so endemic, it's more what they call community spread. You don't have to have a travel history anymore.
Yeah, it's here. Okay. But speaking of traveling, we have had someone who wants to know if they get on a plane and travel someplace else for a legitimate reason, right now in the United States, and they return, should they be self-quarantine? Should they self-isolate for 14 days?
Just the same as they're doing anyways. So I think we're all kind of staying home anyways. Right now, as we've been saying, it's community spread, and there's, unless you're specifically going to a New York hospital and visiting your relative who is in a specifically known high intensity location, then I would say continue to practice your good hygiene practices and follow the order to stay home.
Okay. So we have a couple of questions about vaccines and whether vaccines that have been previously created might help this particular situation. For one was the Ebola virus and another was the old polio vaccine. Dr. Prabhu, talk to us a little bit about vaccines and what's on the horizon for us. What can we hope for with COVID?
Well, I mean, the thing for against the Ebola and the polio is vaccines are designed to protect you against that particular infectious disease. So the previous question that I remember getting elected, does a pneumococcal vaccine protect you against COVID-19? And it's the same analogy for those vaccines. Okay. So I think we're still far away out, year and a half, and it's one thing to develop the vaccine, then you have to test to see how it works and to see how effective it is. There are some vaccines that are 95, 99% effective. Example, the flu vaccine may be 40% effective, so it's to be determined, even if something comes out, how effective it's going to be.
So since I have my two disease experts on tonight, the question really is, ultimately, when can we get back to normal? When can we stop all the safety measures? What do you think might be some of those criteria? And I appreciate that we don't know for certain, but just professional opinions.
I don't know. I don't know the answer to that question. I think that things are going to happen irrespective of whether or not it's safe to do so, and I think we'll find out if it's going to be safe. We might see an upsurgence of infection after we lighten some of these measures, and we might have to respond to those in the future. I don't know.
Don't know.
I don't know when it's safe.
I think there's certain measures that have been taken that can get us to that point. Before, if you asked me 2 weeks ago, we were nowhere close. So the first thing is having access to testing for all people. So then you get an idea, how common is it in the community. And the other measures are, the social distancing, the masking, universal masking of the public when you're around other people. Those sort of measures will make it, at least more the ability to get back to something it's not going to be normal, but working towards that.
So the bottom line, I guess, is we're going to be doing this for a while, whatever the new normal is going to be. Yeah. But I think for those of us in Minnesota who we've worked really hard to sort of stay home and wear those masks and do all the right things, have we flattened the curve?
I think we have, actually. We've done better than any other state in the country. I'm so proud of you. Bravo. Keep up the good work.
That's right. Yeah, I mean, I think that's part of the idea is that we haven't overwhelmed our health systems.
Right.
We know that, I know for both of you, as someone who's practicing, I know that we're regularly inventorying our PPE, we're checking to see how many beds we have contingency plans for additional beds, not just here, but really all around the state, including the Twin Cities. And so I would just ask both of you from your hospital perspective, do you feel like we're in good shape?
At this moment, we are in good shape. We've done a lot of work to prepare, and we've learned about our ability to adapt. I think there's been a lot of exploration of what we're actually able to do when we need to, and it's significant.
Yeah, I think we're at this point in a good position. A lot has to do with preparedness, and it's hard to predict the future, but we're anticipating the worst and hope for the best.
So keep up the social distancing, wear those masks, and do what you need to do, right?
Yes.
All right. So with that, I want to thank our panelists, Dr. Harmony Tyner and Dr. Rajesh Prabhu, and our phone staff and crew for being here this evening, and you, our viewers, who've given us such great questions to talk about tonight. Please join me again next week when our guests will be Dr. Arnie Vigno and Dr. Mary Owen. Don't be lulled into a false sense of security. Continue to practice that physical distancing, wash your hands, and sanitize those surfaces that you touch. Thank you for watching and have a safe week.